Okay. So thank you very much, John. Yeah, that's a good intro. I do have a brief description of a lysosome. So for those of you who may think that amyloidosis is rare and bad, lysosomal storage diseases are worse, or rarer and perhaps badder. But hopefully I can get a bit of a description and work our way through some of them. So I have no relevant disclosures other than to say I myself as well am an echo reader. I'm not an MRI reader, so I do have a few clips in there, but I'm happy to get other input should that be necessary. So to start, I'd like to recognize the clinical and echocardiographic features that overlap and are distinct with lysosomal storage diseases and try to differentiate those from other causes of left ventricular hypertrophy. We also like to look at some of the complementary role which other modalities, specifically MRI, can provide. So a lysosome are membrane-bound organelles found in all animal cells which contain hydrolytic enzymes that break down all forms of biomolecules. So these could be mucopolysaccharides, sphingolipids, glycoproteins, various different things in the cell. Now, lysosomal storage diseases have deficient activity of some of these specific enzymes. And then what happens, instead of breaking down the materials that they're supposed to break down, some of these materials are left in the cell, and that leads to, over time, accumulation and disruption of the cellular function. So I don't want to get into all of the detailed classifications, but there are over 50 liposomal storage diseases, which is difficult to cover in 15 minutes. But when you look at them, I think you can generally say they're generally classified according to their compound or their pathway. So the large groupings would include mucopolysaccharides, lipid storage disorders, mainly sphingolipidoses. So my other disclosures, I can't say all of the words in my presentation. Oligosaccharidoses, mucolipidoses, along with some other lysosomal membrane transport. So that might be the last time I do that. I've found a way to incorporate some short forms in. So I'll start with, and I'll just kind of give a flavor of some of the main ones, and at least the main ones that have cardiac involvement, because not all conditions necessarily have cardiac involvement, and there's a different degree depending on the condition. So mucopolysaccharidosis or MPS are caused by the absence of functional enzymes contributing to the degradation of glycosaminoglycans or GAGs. Over time you'll get progressive deposition of GAGs, which results in multi-organ dysfunction, and it varies depending on the specific condition how much each particular organ system is involved. So the typical clinical manifestations of that can include dwarfism, skeletal and joint malformations. They can have dysmorphic facial characteristics. They can have increased intracranial pressure or other neurological findings, and they can also have umbilical, inguinal hernias, GI, and other problems. They typically have a fairly short lifespan, typically not living into adulthood in most of the conditions, and their and their mortality tends to be from respiratory or cardiac causes. So the primary cardiac issues tend to be heart failure, arrhythmias, frequently heart block, or actually obstructive coronary disease, even in adolescence. So when you look at cardiac involvement, they'll vary based on the type, but in some types like MPS 1, 2, and 6, they can have cardiac involvement that's greater than 60%. The most classic finding is that of progressive cardiac pathology, which involves cardiac thickening and impairment of function. And you can see from this bar graph I have shown there that overall the most common in this area would be left ventricular hypertrophy, aortic or mitral valve issues, or pulmonary hypertension. So this is a example of a patient. At least the echo clips are of a patient. The other pictures I got from an article, but it's of a 19-year-old female who is, and I'll thank my pediatric colleagues for this echo because she's still followed by pediatric cardiology in Halifax, and she has Hurler syndrome, which is MPS 1. So they have a high incidence of associated valvular dysfunction. 80% or more end up having cardiac valve thickening, which I think is apparent on these images. So left-sided valves tend to be involved more than right-sided valves, mitral valve more than aortic valve. And excuse the orientation, but that's how they do them at the IWK in Halifax. But you can see here that there's marked thickening, particularly along the edges of the valve. There also tends to be subvalvular involvement, which was difficult to find a clip to show, but you can get the appreciation there that there is shortening and thickening of the chordae tendineae, and I think you can appreciate how there's tethering of the posterior mitral leaflet in that image, and resultant probably mild to moderate mitral regurgitation. So to conclude, the mucopolysaccharoid doses tend to have left-sided valvular involvement. They tend to have life expectancies less than 15 years in many of their conditions. Echocardiography ends up being a key component of their diagnosis, and at the time of diagnosis they should have an echo, and then depending on the type and how aggressive the phenotype is, they can have further echocardiography every 1 to 3 years. MRI probably doesn't have a routine involvement in this condition, partially because the patient population itself would likely need to undergo sedation to undergo an MRI. Their requirement for pacemakers is relatively high given their need for AV block. So there's some issues in some patients with doing CMR. Okay, time to move on to the sphingolipidoses. So this is a pathway many of you might not have seen before. I'll put myself in that category, at least if I did, I forgot it from my first year medical school. I do have a pointer. I'm trying to point at those green boxes on the right, which highlight alpha-galactosidase A, which are the key component of Fabry's disease. So while again there's many different types of this disorder, the one I'll choose to highlight is Fabry's disease, and I'll do that for a couple of reasons. One, it's probably one of the ones you may actually have to deal with the most because it can present in adulthood, whereas a lot of these other conditions will present in children. So it's a legitimate part of the workup of unexplained left ventricular hypertrophy. In addition, if there is an area where I have a little bit of experience, it's probably in this area because one of the pockets in the world of what is a fairly rare condition is in Nova Scotia, at least along the South Shore. So next year you'll be asking Sharon Mulva to do the talk because in addition to growing wine, she's right in the area where Fabry's is prevalent. So it's caused by a mutation in the gene encoding alpha-galactosidase A, so that means their activity of that enzyme is decreased, thus they get an accumulation of GB3 in their various organ systems. The incidence is felt to be in the range of 1 in 50 to 1 in 55,000 in males. It's significantly less than that in females, but not really well recognized what it is. They can get numerous clinical manifestations, including angiokeratomas. They can get ocular manifestations, including lipid deposition on the cornea. They can have strokes. They can have renal failure and proteinuria, and they can have cardiac manifestations. So the most classic one would be that of concentric, fairly typical, nonspecific left ventricular hypertrophy. Having said that, there are some cases where in later stages they can tend to get more involvement of the septum and perhaps fibrosis and thinning of the basal inferolateral or posterior wall. They can have right ventricular hypertrophy, and at least some areas of the literature will describe valve thickening again from this lipid deposition. The one valvular abnormality which has reasonable data to support it would be a papillary muscle hypertrophy. And there was one study that showed that papillary muscle hypertrophy in the setting of concentric LVH suggests Fabry's as a diagnosis versus other causes of the left ventricular hypertrophy. Okay. The binary sign is a thickened hypoechogenic area that you can see along the endocardial border, again representing of glycosphingolipid deposition on the endocardium with an underlying hypoechogenic layer. Now, while the specificity of this is reasonable, its low sensitivity and poor reproducibility has brought it into question as to exactly how valuable it is as a tool for the diagnoses. But nonetheless, if you see it, it's at least interesting and possibly useful with finding your cause. People with Fabry's disease will tend to have diastolic and in the late stages systolic dysfunction. Longitudinal function tends to become impaired before radial function, and there was one study as well that showed that depressed S wave and E waves on your tissue Doppler can be predictive in patients that they're actually mutation positive patients, so in high risk patients even before the onset of hypertrophy. Speckle tracking and strain has not been extensively studied in this group. A group from Edmonton showed that global longitudinal strain is depressed in Fabry's disease and is significantly more depressed in those patients who have a lot of fibrosis documented on cardiac MRI. So the worse the involvement, the worse your strain. There is, I guess, a bit of a characteristic pattern, perhaps not to the same level of study of amyloidosis, but a strain pattern of worsening strain values in that basal and mid-inferolateral area is sort of characteristic of Fabry's disease. And if you have strain values in one of the affected segments lower than negative 12.5, that was suggestive of fibrosis on cardiac MRI. Okay, so time to move on to cardiac MRI. There is certainly a role for cardiac MRI in this condition. It provides excellent ability to measure wall thickness, accurate estimation of left ventricular mass, and accurate assessment of left ventricular systolic function. And of course, late gadolinium enhancement helps with the presence of fibrosis and scar. So in differentiating Fabry's disease from hypertrophic cardiomyopathy, while generally speaking the pattern of hypertrophy can be similar to that seen in hypertrophic, or at least in a concentric hypertroph, there are some late gadolinium enhancement features that appear to help differentiate. So late gadolinium enhancement tends to be more focal in Fabry's. It tends to involve, again, that basal and mid-inferolateral wall, and it also can have a mid-wall distribution, tending to spare the subendocardium. So I'll just show you a quick picture and try to, oh yeah, if I can get this. Where's my, is there a pointer on this? Use your cursor. My cursor doesn't work. Is my cursor up there? Let's not see it. Oh, here's a pointer. So I'll try to highlight it here. So on the short axis view, here's your septum, here's your inferolateral wall. So you can see focal fibrosis seen along here in the white in the inferolateral anterolateral wall, and perhaps better seen here on a 4-chamber view, septum, apex, lateral wall. You can see this thin band of white here, which is indicative of fibrosis that is sort of in the mid portion of the wall and sparing the subendocardium. Okay. CMR T1 mapping was touched on, and while it's still somewhat experimental in this condition, there is some evidence to suggest that T1 mapping can accurately discriminate against Fabry's and other diseases which cause LVH. And you can see here on the right, Fabry's being down here, other causes such as amyloidosis, hypertrophic cardiomyopathy, or hypertensive heart disease here. And you can see the scoring is quite different when it comes to T1 mapping, between allowing for pretty accurate differentiation between Fabry's and other causes of hypertrophy. That would have been a useful tool in this patient. This is a patient, this is near their end stage of Fabry's, of a patient who had long-standing Fabry's on medical therapy. I think I can easily convince you here that there's concentric left ventricular hypertrophy, mid-cavity obliteration with a mid-cavity gradient, and probably, an apical aneurysm you can see in the apical views there, not out of keeping with a hypertrophic cardiomyopathy. And indeed, this patient very soon after that went on to undergo cardiac transplantation for end-stage Fabry's disease, and the explanted heart actually showed myocardial disarray in keeping with hypertrophic cardiomyopathy in addition to Fabry's. And there is some overlap between the two. Okay, so enzyme replacement therapy can be used in patients with Fabry's disease, and indeed it's been shown to cause, in some patients, regression of LV wall thickness and reduced stroke and renal issues. So to conclude, Fabry's disease has cardiovascular involvement. It is important to initiate treatment in early disease. Echocardiography and cardiac MRI are important in the diagnosis and treatment. These can be valuable, as at least one study showed that Fabry's disease can have a prevalence of 3 to 4% in those with unexplained left ventricular hypertrophy. And these are just some of the ways that I had highlighted to differentiate between with the modalities. So I have about 3 more slides. So oligosaccharidosis are similar to MPS disorders, again with an absence of a pathway. Here's another just example of a young patient. So in this condition, they tend to have aggressive valvular disease, most commonly and this patient actually had mitral and aortic valve disease. She's a 32-year-old female followed in our adult congenital heart disease group, and she's being followed very closely for moderate to severe mitral stenosis now, that, as you can see from this slide. And then finally, I'll finish up with Pompe's disease. This was difficult to find, and I actually had to go all the way to Cape Breton. I included this just because I actually had to, I went through this echo quite thoroughly just to make sure that Dr. Sabidi's interpretation was actually accurate, but I couldn't find any abnormalities. And indeed, this is a patient with this Pompe's disease, which is a lack of acid maltase, but at this stage is on therapy and doesn't have any cardiac manifestations, at least evident on echo. So to conclude, liposomal storage diseases are rare. Many can have cardiac involvement. It's important to consider in patients with unexplained LVH or left-sided valve disease, particularly at a young age, to consider some of these potential diagnoses. Some knowledge of the clinical manifestations and a comprehensive imaging approach is valuable with your diagnosis. And there are, at least in the case of Fabry's, some characteristic echo and MRI findings that can help you differentiate it from other causes. Thank you.